My name's Hamish Hamilton. I'm a General and Vascular Surgeon based NHS-wise at the Royal Free Hospital, and I have a practice at One Hatfield. I have been in practice for about 20 years and I perform a wide variety of general and vascular procedures. There are several different classifications of hernias. We group them into abdominal wall hernias and internal hernias. I'm mostly involved with the abdominal wall hernias. The most commonest are the inguinal and femoral, and then we have the midline or ventral hernias that can be umbilical or periumbilical or ventral or incisional. These are the most common hernias that are presentations to our clinical practice. The most common presentation of hernias vary with the age and sex of the patient. Femoral hernias are more common in ladies, especially elderly ladies, whereas younger males, for instance, would present with groin hernias that may be related to work or physical exertion. Obviously, after surgery, the abdominal wall is weakened, and so an incisional hernia could occur in anyone who's had previous abdominal surgery. The most common presentation of a hernia is with a lump, and the lump is typically there when the patient's standing, and when they lie down the lump disappears. This can be a bit disconcerting for patients, A, because there's a lump and they wonder what's the cause of it, and B, because it disappears. The hernia can also present with pain, a dragging sensation in and around the hernia site, and on a rare occasion bowel can get caught in the hernia, and that may present with bowel obstruction. Most hernias that are symptomatic are treated, but on the odd occasion when there's a small asymptomatic hernia, it can be observed and monitored by the clinician for a while. The larger ones, which have a higher probability of entrapping bowel, generally need to be fixed, and so we base our treatment regimen on the symptoms, the site and the presentation. Hernia surgery, I would say, is an intermediate surgery, mainly because it's superficial, soft tissue and related to the abdominal wall. But if there's bowel involved, it can take on different connotations, with the bowel needing to be repaired or freed from the hernial sac. Most hernias are now fixed laparoscopically, which is keyhole surgery using minimally invasive techniques rather than making a large cut. And the benefits of this are reduced perioperative pain and an easier return to work and a better recovery in general. Most of the procedures we do, as they're laparoscopic, would require general anesthetic because one's accessing the hernia site through the abdominal wall. Hernias can be fixed under local, and an open hernia repair could be done in the groin quite easily under local anesthetic. But in either event, both are day case procedures which are easily tolerated in the patient home that same day. After hernia surgery, most patients have several days of local discomfort that can be treated with anti-inflammatories. More importantly, in the longer term, one would avoid heavy lifting for about 6 to 8 weeks after the hernia repair, so the abdominal wall can heal and the repair become firm. I would recommend that we modify that based on the patient's occupation and their home circumstances, but we would use that as broad guidelines after the procedures we do. In modern day hernia repair with mesh, which is the synthetic patch that we place over the hernial defect, recurrences are low because the idea behind the patch is it's a tension-free repair. So in general, the recurrence after hernia repair has fallen since we've used this technique. And the technique is to place the mesh laparoscopically, which is effectively the same idea as placing the mesh via an open technique, but just using a different access. If you're concerned that you have a hernia, you notice a lump that is palpable, you could be seen at the One Hatfield Hospital. We would examine you clinically, possibly get an ultrasound, which would make the diagnosis clearer, and your treatment would be on that basis.